I want to welcome everybody tonight. It is Thursday evening on the 11th of December, 2025. The year is almost over. I want to welcome you all to the Baltimore County Fire Department Emergency Medical Services Academy Training Series. Tonight we have the honor of Dr. Rishi Kundi from the Shock Trauma Center in Baltimore, who's going to be talking to us about cervical spine injury and C-spine immobilization. Dr. Kunji is a vascular surgeon and trauma surgeon at the Shock Trauma Center, and is also part of the rapid deployment team they have there, the GO team, for field exercises. And so it's also possible that any of you, and at least in Maryland, could see Dr. Kunji show up on one of your calls if you request the GO team. Um, and it would be you'll have a very good time. I want to welcome Dr. Kunji, and I'll let you take it from here. Thank you so much.
Great. Thank you so much, Dr. Sagal. Hi, my name is Rishi. Today I'm going to be talking about C-spine immobilization, which, as a subject to me, is very interesting because literally everyone at every point along the chain of care bitches about this. I know that pre-hospital, the debate is why are we doing this? When a patient is in the hospital, the road to clear someone's spine and get the collar off, if particularly they're either unreliable or they are unconscious, is painful. And so I thought it was a good idea just to go over the evidence we have and ultimately why we're doing this. So with that in mind, I'm going to talk. I am going to try to minimize the amount of statistics that I talk about. This is really more of a conceptual talk, and it is absolutely a discussion. This is a back and forth. So if you have any questions, please, I have my little chat window up, and I have absolutely no problem stopping and talking about things. So let's get started. If I can do that. There we go. Okay. All right, so let's start with the basics. Why do we care about protecting the spinal column and the spinal cord? The incidence in the US is somewhere between 23.1 and 83 cases per million a year. In Canada, it's 17 to 109. This is from a very, very large systematic review. It's hard to judge exactly how prevalent this is worldwide. And just to give you some idea of comparison, the incidence of MI is 2,000 per million per year in the world, and stroke is 550 per million per year. So even at the top end of those estimates, we're talking about something that happens enough that you should worry about it in your patients, but not enough that there is an epidemic of quadriplegia that we are neglecting necessarily. So everything I'm going to talk about with regard to C-spine immobilization actually started with this article from 1944. This is from the Canadian Medical Journal, but it is a report of a method that was told to the Canadians from London. And this is kind of interesting because the problem that they faced in London was that the Germans were bombing the city and they had to get people who were injured out of their homes without worsening the injury. And so they came up with these methods to carry people out of homes that had been bombed. And they are very elaborate. And then in response, someone wrote to this, a Canadian wrote that the facilities and time would not be available if you're being actively bombed to carry them in this, very elaborate, although improvised fabric system. And so they said, well, the priority is to immobilize the spine in something approaching the natural contour so that no flexion could take place. This right here, this paper is where it all started. It's not even a paper really, it's just a report. So this is the second one that started the way we do things, and this is an actual case series from 1952 that looked at 87 patients over a decade each of whom had a fracture dislocation of the C-spine. And what is notable about this is that I'll show you in a moment, a significant proportion of these patients had worsening neurological function after their injury. This is actually a quote from the paper. It is a sad commentary that 1 in every 10 patients, symptoms of core compression or an increase of symptoms developed subsequent to the time of original injury, during emergency care, during the time when the diagnosis was being established, during definitive treatment, or following a reduction. That brought up the issue of worsening a spinal cord injury. And here you can see 10% had a late increase of cord symptoms from these patients. And the solution to this by this writer was that it is the responsibility of the first responder or the trained aide who's first called upon to institute emergency measures which will protect the cord, specifically traction applied in the direction of the long axis of the spine, which is the principle behind the hair traction splint, right? In the neutral position will protect the cord, which is escaped injury, uh, subsequent to fracture or dislocation of the cervical spine. And so this device was invented. And this definitely is going to be something that is familiar to you all. So then let's skip forward, because the reason we're skipping forward by about 45 years is that there is, at this point, after this point, when they said, hey, people are getting paralyzed because of how we're transporting them and how we're positioning them, we have to keep their necks rigid. No one really questioned it or looked at it again for, 50 years. And the reason for that is instinctive, and it's something that affects you and me, which is if we have a patient who enters our care at the scene of injury, uh, and we move them, and then the patient becomes paralyzed, that's the worst possible outcome. Like it is something that we are afraid of. Um, let's see, sorry. Okay. So this is a very interesting paper, as I said, 50 years after the first one describing the collar. Two centers looking back over 5 years at a total of 454 patients who had either a spinal column or spinal cord injury in Malaysia, and I believe it was New Mexico. The Malaysians didn't use any pre-hospital immobilization, and all of the Americans had immobilization. And what they found was, well, the distribution, by the way, of the area of the spine that was injured was pretty consistent. And the mechanisms were very, very similar, with the uh, exception. And remember, when you're looking at mobilized versus immobilized, what you're looking at is American versus Malaysian. Which is that way more Americans suffered from vehicle crashes than in Malaysia. And no, this is once again looking at this. Uh, if you look at the odds ratio for disability was higher for patients in the United States, meaning it was higher for patients who had immobilization. Even after you adjust for all of these other variables, right? After you adjust for the mechanism, the level of injury, the gender, age, doesn't matter what it is. If you immobilize the spines, you ended up with a greater instance of neurologic injury. And it was such a drastic difference that they calculated that the chance of a type 2 error was 2%. Meaning the chance that this does not represent reality is 2%. There is a 98% probability based on this data that immobilizing the spine is harmful or of no value. So then they said, let's just take the C-spine patients out of this. And what they found was that there was no protective effort of spinal immobilization. It wasn't as bad as all comers. If you looked at all comers, if you were immobilized, there was a greater chance you would end up with a worsening injury. If you just look at cervical immobilization, there was no difference. So here in the first big paper about this, we find that there doesn't seem to be a benefit, which didn't stop anyone from doing it because the paranoia about something you're not doing resulting in paralysis was so great. And so sorry, um, this was a study that was underway in the UK. It was called the Spinal Motion Restriction Feasibility Study, or the SMRFs, uh, which was prospective, interventional, single institution. And what they wanted to look at was not should we immobilize or not immobilize, but do we really need to put the collar on, or can we just use the soft blocks on either side of the head and tape the head in place? So if you use everything, blocks, tape, and a collar, that is triple immobilization or full spinal immobilization. And this was an exhaustively planned study. The permissions involved were very extensive. As with any pre-hospital study, you have to really get community consent. And what they found was that no one in either group had any neurological injury, and so the Smurf was dead on arrival. So here we have a multi-center retrospective study. This looked at all adults greater than 60 years old with cervical spine injury. Now, this is actually pretty important because older patients inherently have more often than not, degenerative disc disease, right? They don't have normal MRIs. They don't have normal CT scans. When you look at their cervical spines, very often they may even have some degree of disability at baseline. And so looking at them especially is a very good idea. And we'll get into reasons why we're even worrying about color or no color in a moment. They looked at 237 patients, roughly half with full mobilization. And whereas the Smurf study looked at blocks and tape but no collar, this looked at a collar but no blocks or tape, which has the benefit of just being faster. You slap a collar on a patient, you take them. You don't have to really put the blocks on, do a whole production. And what they did was, rather than look at each simultaneously, they just implemented a protocol. They measured outcomes before the protocol, and then they instituted the protocol, and then they measured it afterwards. And this is their spinal precaution, this or protocol. This is when they decide that they need any kind of immobilization at all. And at the end of the talk, we'll talk about um, those factors that feed into deciding if someone needs immobilization or not. And if you have none of these, you don't need any spinal precautions. And you just take the patient on a gurney with a cervical collar, not full spinal immobilization. And what they found was that if you just use these rules, you ended up with a full cervical collar way more, and you did full mobilization way more, and you did no immobilization at all way more as well. And there were no differences in outcomes at all. The neurological deficit when the patient got to the hospital did not change. It did not change where the patient went after they left the hospital. And really interestingly, when the patients arrived at the hospital, there was a decrease in either mortality or discharge to hospice. There is a lot of evidence that if you put someone who is frail, a lot of evidence, there are two papers I read, that if you put someone who is frail in a collar, it makes deep respiration more difficult. It affects their sleep and it affects mobility. And as I said, sometimes the protocols for taking these collars off once they're on and the patient's in the hospital can be very painful. So you're looking at, days, maybe a week of the patient taking shallower breaths than they would like to, which leads, of course, to atelectasis, and then you have pneumonia, and then you have an increase in mortality. And of course, there are very few things that help someone get out of the hospital healthy, um, than just being able to walk around, right? Mobility, a lack of deconditioning. So we have this. This is using soft cervical collars rather than the hard collars, the Jersey, the Miami J. Um, this is just a pretty firm foam collar. And these folks, multi-center, this is Australia, and I forget where in Micro and Micronesia it was. And the question was, if you put some patients in a soft collar, are there any patients who suffer from that? And they divided patients into these groups. After the patient arrived in the emergency department, they fell into these categories. Uh, they came in without a collar, but they could not be examined or cleared, meaning that they still potentially could have a cervical spinal injury. Those folks got a soft collar until they could be imaged. They came in with a hard collar, but for whatever reason, they couldn't be cleared. Usually, these are patients who are unresponsive or they're extremely intoxicated and can't be relied on for an exam. They also got a soft collar until they could get imaging. Now, if that imaging showed an injury, well, then they got the hard collar. If it showed no injury, but they remained unreliable, then the soft collar stays. And if the patient came in a rigid collar and had a neurological deficit, the rigid collar would stay in place. Now, what they found was that amongst the patients who had a soft collar, uh, 0.5% had a new neurological deficit after they got into the ED. That was less than the patients who had a rigid collar placed. Um, And of those patients who had a new neurologic deficit after they arrived in the ED, two of them, no one had any idea why. Three of them was because they had intracranial injuries, and only one of them was because they had a spinal injury. If they had a rigid collar, double that. Now, admittedly, that I mean two patients compared to one had a worsening of their spinal cord injury. And if these patients were judged, if they came in with no collar at all, they had nothing bad happen, which just means that the judgment by the pre-hospital providers that the patients did not need a collar was accurate. So let's look at those three patients who had worsening neurologic deficits that were secondary to um, spinal cord issues. These are between the soft and rigid collars. Now, in one of them, it was because cord edema developed. Um, and another one, there was an epidural hematoma. And the third one was questionably quadriplegic on arrival, but it was difficult to assess because they were extremely drunk. Now, this is relevant because what we start to talk about is that patients do get worse. They have worsening spinal cord injury, but it's not because the C-spine is unstable. It's not because the cord's getting torqued around and torn more or stretched more. It's because of the natural progression of the injured cord, meaning you have edema in the cord that worsens its function, or if there is bleeding within the spinal canal, that bleeding can compress the cord and worsen injury that way. These are both things that we see after you bring us the patients, not infrequently. And these are the patients who will go to the operating room not to get fused necessarily or get stabilized, but to have the hematoma, to be decompressed, to have the hematoma evacuated. And the cord edema was the thinking behind, in the late 90s, whether these patients should be getting steroids, which obviously did not work out. That worsened things for everybody. So the odds ratio for worsening injury, if you had a rigid collar placed, the chances that you were going to have a worsening neurologic exam after arrival was 400% higher, 411%. And so the rigid collars were associated with worsening spinal cord injury. It's just that that worsening was not from the dislocation and the instability that we were worried about. So talking about kids, this was prospective, single study. Uh, they looked at children with a suspected cervical spine injury, pre-hospital suspected. 173 of them had what we called movement minimization, which means they got the collar or the board. And 112 had no immobilization whatsoever. And what does that mean to have suspected cervical spinal injury? Well, this was a joint statement from a bunch of pediatricians and trauma surgeons, which is this, because kids are hard to judge anything, right? It's very hard to have a kid tell you, what their neurologic exam is. If you ask a 3-year-old if they're experiencing any paresthesias, they're probably not going to give you a very good answer. So the Pediatric Emergency Care Applied Research Network, which, as I said, is a combination of ER physicians, trauma surgeons, pediatric surgeons, said that if a kid complains of any neck pain, or if they've torticollis, which is when your neck hurts so much that you don't turn it and you're walking like RoboCop a lot. One moment. Or if they had obvious neurologic deficit, altered mental status, or importantly, if they were involved in a high risk mechanism, then they were suspected of being at risk for a spinal injury. So here are the two groups. The age for spine mobilization was 11, not spine immobilized, but they met those guidelines for spine immobilized. So these were patients who the guidelines say you should immobilize them, but they just did movement minimization was 7. And this is actually an important point because if you put a 7-year-old in a very uncomfortable collar and you tie them down and you make sure they can't move, they're immediately going to start struggling. Right? They're going to start taking things off. They're going to start screaming. And if a kid is screaming because he feels like you're holding him down, it becomes really difficult to tell if he's screaming because he's hurt. An 11-year-old can tolerate movement minimization a little better. The mechanism of injury, pretty much even. Small kids fall more. We all know that. Uh, when you look at the patients who are brought in by EMS, most of those patients ended up with spinal immobilization. Glasgow coma score was fine. There were 15 in each, and the pediatric trauma score was the same in both. What they found was that if you immobilized a kid before they were really evaluated, they had greater pain scores. 800% more of the kids who had spine immobilization had to undergo imaging. They ended up staying in the ED about the same time. If they weren't spine immobilized, they went home more often. So, of that whole group, only one kid actually had a spinal injury. This was a kid who was spine immobilized because there was high suspicion. And it was a 13-year-old in a car accident who had multi-level spine injury that required operative fixation. The injury was suspected on plain film and confirmed by CT scan. No actual neurologic deficit. This is exactly the case that you are worried that you could screw up, and this one was handled perfectly. So this is interesting. This, I believe, was in Singapore. It is a retrospective single center study looking at 1 year of patients who came into a single hospital after a motorcycle accident. Okay, at low or moderate speed. Now, to give you an idea of what we're talking about little Asian city bikes, right? Less than 150 cc engines, less than 50 kilometers an hour, and they were all brought in by EMS. In 1 year, one hospital, low velocity motorcycle collisions, 5,000 patients were brought in. About half of them had cervical mobilization, and half did not have any mobilization whatsoever. Really, the thing that jumps out at me is how frequent admission for I mean, motorcycles must be crashing at a rate of like one every 3 minutes in every block in this city. There were 63 patients with cervical spinal injury. 51 came in immobilized, 47 had a neurological deficit, and 16 had to go to the OR. There was no association seen whatsoever between whether the patient had a collar or whether the cervical spinal fracture was unstable. So the conclusion of the investigators were if a patient has neck pain or supraclavicular lesion, a neurologic deficit, and a suspected intracranial lesion, that's those three criteria actually determined which patients should have been immobilized. So it brings up the question, those are three things that pre-hospital providers can identify at the scene. And everyone else, the people who don't have this high suspicion, um, don't need a collar. So uh, all of you are at least somewhat familiar with ATLS and pre-hospital trauma life support guidelines, which really just stress immobilization at the scene. You have to keep everything immobilized. If you intubate the patient, obviously all of these things. So, prospective multi-center observational study looking at this protocol. 127,000 patients were admitted between 86 and 2020. They divided these patients into four phases. The first is 86 to 95, before there were any ATLS spinal protocols. The second was the 9 years while while these protocols were being implemented. So kind of a transitional liminal period. From 2006 to 2015, everyone was using these protocols everywhere. And from 16 to 20, they were looking at a revision of the protocol. So same protocols, but they underwent a revision. And what they found was interesting. So with this gradual implementation or absence or revision of these protocols, what's the rate of spinal cord injury? How did these protocols affect spinal cord injury with this enormous patient sample? So when you look at spinal fractures without a spinal cord injury, statistically, it's pretty stable, right? Which makes sense um, because these patients are still breaking their necks. Uh, but if you look at those patients who broke their neck and who came in with a spinal cord injury, as the protocols have been administered and as they've been revised, the rate of spinal cord injury has increased. And then if you look at the percent of spinal fractures with spinal cord injury, that's also increased. So the same number of people are having their necks broken, but a greater proportion of them are coming in with spinal cord injury. Now, assuming that people aren't increasingly taking up dangerous hobbies, if they are arriving at the hospital with the same number of spinal fractures without a spinal cord injury, an increasing number of fractures with a spinal cord injury, which together, obviously, with an increase in proportion with spinal cord injury, then the protocols are making things worse, right? And if you look at the numbers, these are absolutely statistically significant. period over period. As soon as you institute the protocols, the percent of spinal fractures that have spinal cord injury increases. When you revise the protocols, it gets worse. So this is actually a very big paper. I think this is why a lot of EMS physicians and pre-hospital providers, paramedics and EMS providers have been talking about C-spine fractures. And this is a really heroic undertaking where the literature regarding cervical spinal injuries was exhaustively examined, right? They found 3,000 some papers from the Web of Science, from Sinashal, from PubMed, from NBase. They screened all of those records, excluded some, and with upwards of 10,000 papers that they found, they ended up looking at 115 studies. That's 115 studies that were evidence-based and that actually looked at spinal cord injuries pre-hospital, from a pre-hospital care perspective. 115 studies, that's it. Of those, 15 looked at the pathophysiology of worsening injury, 58 looked at the effectiveness of spinal immobilization, an equal number looked at harms, and 6 of them looked at other factors. And when they looked at why spinal cord injuries worsened, 2 papers said, oh, it's because the spine moves. Both of those papers were before the advent of MRI. One of them was from 66 and one of them was from 88. And as soon as MRI became part of the assessment of spinal cord injury, nobody wrote about it anymore. Instead, what they wrote about, what they were finding on MRI, was that you had cord ischemia, you had cord edema, you had cord bruising, and you had vascular injury, specifically vertebral artery injuries. Now we talk about harms, because I've said multiple times that what gives us nightmares, what keeps us up at night, is the idea that, we're going to worsen a spinal cord injury. So isn't the safe thing just to put the collar on? Isn't, there's no downside to a collar, right? You're just keeping the neck still. Well, here's the literature about it. There is harm to the airway. I've already spoken about the respiratory difficulties that come with wearing a collar. It increases your intracranial pressure, and the coincidence of traumatic brain injury and cervical spinal injury is obviously extremely high. The straight assignation of a worsened neurological outcome to the use of a collar I've mentioned before. There's one paper that demonstrates it actually worsens the dissociation, atlantoaxial dissociation, and a dozen papers that point out that these patients develop pressure ulcers, which is something we see in our patients all the time. If a patient comes in and they are unresponsive and they have a cervical spinal collar on, and you leave that on for a week, they will end up getting horrible ulcers at the top of their sternum, on their chin, on their mastoid process, everywhere where the collar rubs against the skin, they will have skin breakdown and an ulcer form. The presence of a collar also causes missed injuries. That has been written about and demonstrated. It causes a delay in care. I can tell you right now that when we have patients who have facial fractures, the fact that they have a collar on will make our facial surgeons and our ENTs say, we can't operate with this until that collar is off. They very clearly have an increase in radiology usage, which I'll explain why in a moment. And then something that has been evident for 30 years and has been demonstrated objectively is that they hurt. They're really uncomfortable. I advise you to try putting on a rigid collar at least once, and you will take it off after about 30 seconds because it's really, really uncomfortable. So what about the whole point? We've talked about the harms of C-spine immobilization. These are papers with good evidence that show that it can increase the spinal column movement or has no effect whatsoever. And again, when you put that C collar on and you try it on, you'll see that you can actually turn your head back and forth. You can bring your head forward and back. It limits it, but it certainly doesn't eliminate it. So this is the big thing we were trying to prevent, right? Delayed neurological injury. The vast majority shows that it has absolutely no effect on development. And there is evidence, good literature, showing that it actually causes it, presumably by that extension, that C1, C2 dissociation that I mentioned. There are zero papers, no articles, showing that the use of a collar prevents neurological injury. So the whole point of why we do this, there's no evidence supporting it. There's plenty of evidence of its harm, no evidence that it does the thing that we want it to do. And that's the conclusion of the paper. Despite historical precedent, there's no literature demonstrating clinical benefit to spinal motion restriction. In fact, efforts to restrict movement cause harm and may have a paradoxical effect. So the idea is that you can make the spinal cord injury worse by moving an injured neck. That's where this all came from. And the data shows that, yeah, some patients do get worse when they have spinal cord injuries. They get worse when they're being taken to the hospital after they're admitted. They can get worse, but that's not why. It's not because they're moving the neck around necessarily. And I've also shown pretty clearly that there's evidence that there is harm associated with it. So what's the problem, right? That's all definitive. That's pretty straightforward. We should throw the collars away. Well, the problem is that there is a thing as an unstable spinal fracture. And there is probably a patient population for whom the risk of a collar is outweighed by the benefit, because the thing when you look at these enormous registries is that there are subgroups that have not undergone subgroup analysis for whom this collar is useful. So how can we find these patients? How can we find them how can pre-hospital providers find the patients who will benefit from a collar more than they'll be harmed? So I'm going to talk about what we use when you bring us the patient to clear a collar, what we use to decide that a patient does not need the collar. And there are two ways to do this. And both of them started not with clearing the collar, but with deciding which patients needed CT scans or MRIs. Because when those technologies arrived, the temptation is obviously to stick everyone into the CT scan and say, great, that's wonderful, you're okay. Can't do that. So these are the nexus criteria. This is developed by radiographers who looked at those studies that showed the presence of a cervical spinal injury. And they found 5 criteria. One, the patient has no tenderness at the posterior midline cervical spine. You feel back here, you press, does that hurt? Nope. They have no focal neurologic deficit, obviously, right? They have a normal level of alertness, no evidence of intoxication. So you're drunk or you have a subdural hematoma and you're kind of drowsy and out of it, you can't clear those people. And they have no painful injury that might distract them from the pain of a cervical spine injury. If someone has a broken neck, that kind of hurts. They may be distracted from that by the fact that they have an open tib fib that really hurts. And what they found is that if you use these criteria to decide who needs cervical spinal imaging, you have a sensitivity of 99% to pick up cervical spinal injury. You have specificity of 12.9%, which means you still have some patients, significant amount of patients, who don't have injury that are still getting imaged. But everyone who has an injury, you're not missing anybody. And the positive predictive value, or the negative predictive value rather, which is the big thing, you want to rule out patients, was 99.8%. Now, if you just look at clinically significant injuries, meaning something other than, a spinous process fracture, the sensitivity increases to 99.6% and the negative predictive value is 99.9%. So that's the nexus criteria. To go over, look how simple this is. These are absolutely things you can determine at the scene. You can determine them in the back of your ambulance. And then there's this one, the Canadian C-spine rule. This is actually the one that I like. And here we'll walk through the steps. The first, are there any high-risk factors that make you really required to get some kind of radiography? Well, if their age is over 65, we talked about why that's true. These people don't have normal necks to begin with. And even if they have a normal neck, they don't have normal flexion and extension. It takes very little for a 90-year-old to break their neck compared to a 14-year-old. If there's a dangerous mechanism, which is defined as a 5-stair fall, any kind of axial load to the head, diving into a pool, for instance, we had a young woman who was walking past a high-rise under construction and a wooden pallet fell on her head from above. She is a quadriplegic now. High-speed MBC, ATVs. We have several patients on my service who have ATVs right now.
Yesterday, it was kind of funny. I double dipped. I went up the station. I had this.
Yeah. I'm sorry, was someone going to say something? No. I'll keep going then. All right.
Yeah.
Or paresthesia in the extremities, which are obviously indicative of spinal cord injury. If they didn't have that and they had a low risk factor that lets you assess the range of motion, right? If you just got rear-ended, or if the patient's just like sitting in a chair in the ED, if you saw them walk around, or if they started complaining of neck pain a half hour, an hour, hour and a half after the actual accident, or if they didn't have that midline C-spine tenderness, those are low risk factors. If they don't have any of those, then they go to radiology. If they do have those low risk factors, then you get to go to them and ask them to rotate their neck. And they just have to basically go 45 degrees right and 45 degrees left. And those patients do not need further imaging. I'm talking a lot about imaging, I realize. The sensitivity of that is 100%. You will pick up everyone who has a C-spine injury. The specificity is actually extremely good. It's 42.5%, meaning that a smaller number of people who don't have injuries are getting radiographic studies. So now people said, well, why don't we take those rules, which are so good at picking up spinal injury, and instead of using them to determine who gets a CT scan or an MRI, why don't we use them to see who needs a C-collar? And this was a meta-analysis, so it looked at 5 different papers looking at clearance. And the negative predictive value of these range between 99.4% and 100%. The sensitivity was as low as 90.7% and as high as 100%. Meaning that if you use these rules to go to a patient and say, I'm going to take that collar off, you don't need it, you're going to be safe. And the Canadian C-spine rule, a modified version of it, is what we use at Shock to take collars off of patients. What we'll do is we'll go to a patient. They have to be reliable. They have to be able to communicate. We'll take the collar off and ask them to hold their neck still, palpate the back of the neck, see if there's any pain. If there's pain, they fail, they need imaging. If there's no pain, we ask, turn your neck from right to left. Any pain? Nope. Okay, try to touch your ear to your shoulder, both sides, pain, no, okay. Touch your chin to your chest. If you can do all of those things, then you don't need a collar anymore, and you don't need any imaging. If a patient is unable to participate in that, but you want to get the collar off for the reasons that I talked about before, those patients get an MRI, which in itself is somewhat controversial. There is a lot of evidence that the quality of CT scans now, because the CT scans now compared to the scans that, we had even 10 years ago is remarkable. We have 128 slice multi-detector scans that can take pictures every half millimeter, which is such a high sensitivity that using a CT scan is only slightly worse. And by slightly, I mean 0.5% worse at picking up C-spine injuries than MRI. What MRI picks up are ligamentous injuries. So what if instead of waiting until the patient's at the hospital to use these rules, what if we just taught it to paramedics? We taught these, I mean, it's not a complicated exam, right? And so the same guy who came up with the C-spine rule said, I'm going to teach it to paramedics, and I'm going to let the paramedics decide those patients who are at risk for C-spine injury. Single center, prospective, 4,000 adult blunt trauma patients. And this is not all one flowchart. These are two flowcharts. So, like I said, is there a high risk factor that mandates immobilization? If there is, they get the collar. If there isn't, is there a low risk factor which tells me it's safe to move their head around? Yes. Okay. Can they move their head to left and right? Yep. You don't need a collar. If the patient fails any of those, they get a collar. So of those 4,794 patients who the paramedics assessed, they found just over 4,000 were ineligible. The ones who were not ineligible were most often patients who had a GCS less than 15. They were kids. It had been more than 4 hours since their injury, so it was not clear when the pain started. They had unstable vitals. They were paralyzed to begin with. And penetrating trauma. If a patient has penetrating trauma, even if it's in the neck, the likelihood that they have an unstable cervical spinal fracture is vanishingly small. And if they do have a spinal cord injury, it is almost always a complete transection that cannot possibly be made worse. So of those 4,000, only 10 had an important C-spine injury that was correlated with abnormal imaging. Okay, so let's go through the assessment. What they found was in the hands of paramedics, the sensitivity of the Canadian C-spine rule to place a collar at the scene of injury was about 91%. The specificity was extremely high. So what I'm saying is that ideally, where I would like us to go is for you guys to decide who needs a collar with an evidence-based way of evaluating them, namely the modified C-spine rule. We know you can do it. We know you can do it safely. We know that the patients don't suffer. And if you add that to the fact that the C collar probably doesn't, that the absence of a C collar probably doesn't really hurt that many people, I think this is safe. I think it's safe for you guys to decide who needs the cervical spinal collar and who doesn't. But this is interesting. This is the last paper I'm going to talk about. And that is the other factor in pre-hospital care that you should take into account is this. If you see a patient and you say, I think you need a collar, and the patient says no, this is a single center retrospective study. This was at Cedars-Sinai in Los Angeles. 629 patients who failed either the Nexus or the Canadian criteria. 601 patients said, all right, you're the boss. I'm going to wear the collar. Please take me to the hospital. 28 uh, said, you guys suck. You don't know what you're talking about. I'm not going to wear the collar. Take me to the hospital. If a patient refused the collar, but the paramedic thought the patient needed the collar, they were statistically more likely to have a cervical spinal injury, meaning that the patient's refusal was predictive of a fracture. And I will end here and open it up to questions.
I find this very interesting and fascinating. Why do we do it? Because that's the way we've always done it. But what's the reason behind it, and is it correct?
Ultimately, the reason is because the Germans bombed London.
Technically, that's very correct. It's weird because you feel like your mind just tells you you've got to hold it still or it'll get worse.
Mhm.
But the statistics are telling us that might not be true.
So
So
the
that's a theory.
it's really counterintuitive, but the best explanation I read from a neurosurgeon was that the amount of force necessary to displace the cervical spine sufficiently to cause a spinal cord injury is enormous. And the likelihood that that degree of force can be applied during transport is really, really minimal. Um, Now, if the patient is completely unstable, meaning that they're, internally decapitated, that's a different question altogether. And
Right.
that, atlanto-occipital and atlantoaxial dissociation is something that does occur. So there is a subpopulation of patients for whom it makes sense.
I've seen internal decapitations a few times. I actually had one of the medics bring a patient who had a C1-2 fracture and a C7 fracture. The patient launched through a windshield when it hit a tree at a very high rate of speed. The patient was intoxicated. They put a C collar on him. Looking at his neck just before we intubated him, it's like all that larynx looks pretty anterior. I intubated him very carefully with a glide scope. He was moving his feet, and then when we looked at the X-ray, we saw the three fractured vertebrae, 1, 2, and 7. And I was like, "Holy cow! We should have tricked him." But they did, I think, an amazing job for keeping him from becoming a paraplegic.
We
So
have a patient who has an AO dissociation and has no neurologic deficit now.
yeah,
All right,
very
let's see.
lucky.
Are there correlations with comorbid pelvic fractures, Lefort fractures, scapular fractures with cervical fractures? I don't know. I would think so simply because the high energy mechanism that causes those uh, is also, you're approaching the level of energy that causes cervical spinal fractures. But I can't give you a number. I can't quantify that association, unfortunately.
Hey Rishi, thanks for coming on to give an excellent talk.
Hi,
How
Jeff.
long, how long do you think the greater trauma world, whether it be Trauma Net in Maryland or everyone, comes on board with the this is actually a harmful intervention? You want to speculate 1 year, 2 year, 5 years, 10 years till we see these things into oblivion?
I think that it's going to happen in stages because the interesting thing is, Jeff, that the ones who are driving this conversation uh, are EMS paramedics and EMS physicians. The greatest resistance is coming from trauma surgeons. Last night, okay, last night, well, night before last, had a young girl come in who had PSYWORA, right? So she had neurologic deficit, spinal cord injury without any radiographic abnormality. Her MRI was completely normal. This happens occasionally. And her neurologic exam improved while she was there. So she kind of just had, uh, I don't want to say she had spinal shock, but she had just a brief blow to her spinal cord and she had transient neurologic deficit, not an unstable, nothing wrong. with either her bones or her ligaments. And the neurosurgeon said she should be in a collar for 8 weeks. Why? She had no instability. If you look, her MRI was entirely normal. Her neurologic exam was getting better. Why are we putting her in a collar? Um, so I think the greatest resistance is going to come from the people inside the hospital building, uh, and it's going to happen in stages. I think that EMS physicians and paramedics and the EMS uh, will probably have to lead this charge, and I think you'll see the change happen pre-hospital first. And I'm going to say 5 years. Um, am I saying that the MD protocols may change again to the criteria you described this evening? Yeah, but no time soon. I hope they do, but not anytime soon. This has just achieved the level of controversy, and the time delay between the onset of controversy and policy change is, one that's measured in years, certainly.
I will point out that people at the present time should follow the current Maryland protocol if you're in the state of Maryland. Um, None of this has come before SEMSAC yet.
Oh, please don't take this as me advising people not to do what your protocols say. Nobody should get in trouble because of a PowerPoint. I mean, for what it's worth, I'm not going to start. I am still going to take my C spine collars off of people the way that, our protocols say. I may disagree with it, but I also like my job. Makes sense to record observations per Canadian protocol so this can be mined in the future. I think that makes sense. It makes local sense. So yes, this is, I mean, obviously I talked about other people who have done this, but I think that there is a particular effectiveness regionally, irrespective of what you're talking about, of saying, hey, not only does national multi-center data say this, but we have looked at this in our hospital, in our regions, with our fire rescue squads. And our results here, we're not special. Our findings are that it completely mirrors what we see nationally or worldwide. So I think it makes sense. I think there's value to it, certainly. Thank you you're very welcome. I hope this wasn't too breezy or informal. Well, everyone's saying thank you, so I think that means that people don't have questions and they don't think I'm terrible.
It's definitely very fascinating and incredibly interesting information because it seems well documented. It goes against the grain or what's become dogma for the many years I've been here. But I would still follow the protocol because you'd think just the opposite in your mind, at least. It seems rational.
It does, it's intuitive, but a lot of things are intuitive that end up not being.
Why do we do it? That's why we've always done it. But
Yeah.
why? Well, what are we accomplishing? Well, I'll remind everyone there's a link in the chat for continuing education. Please hit it. And I thank you all for coming. We will see you again in 2 weeks. While we're here, I want to congratulate Chief Nats on her promotion. Well earned, well deserved.
Yes.
Thank you.
Okay, well, thank you everyone for coming. We'll hang for another minute if anyone has any questions. Otherwise, have a wonderful evening.
I am going to put my email address in the chat if anyone wants to send me questions afterwards. And Jeff Nussbaum knows how to reach me. Is my cell phone number. We talk all the time, so you can always get him to put us in touch. All right. All right. Good night, everyone.